Good morning. I'm Tara Register. I am a patient educator with the Mayo Clinic Cancer Education Program. I will be moderating this session this morning. We are glad you are here with us for this live webinar titled Melanoma Skin Cancer Awareness, presented by Sydney Schone, a Mayo Clinic Radiation Oncology Nurse Practitioner. We want people on this webinar to know that this session is being recorded, so individuals who are not able to attend us with us during this live session, that they can watch it later. For those who would like to view this webinar again, the recording takes about 3 days to be edited and put on the video library tab of our cancer education group on the Mayo Clinic Connect page. The Mayo Clinic Connect page is a digital platform where patients, family members, and caregivers can connect, get evidence-based information, and get access to information about classes our center offers. We encourage you to follow the cancer education blog on the Mayo Clinic Connect so you can stay up to date on upcoming webinars and other educational opportunities. We will put the link to Mayo Clinic Connect Cancer Education blog in the chat. You can click on the classes and resources tab to find out more about our classes. I would also like to make a quick announcement for the upcoming webinars in May. The topics included will be our 2 webinars that are left in our 3-week series of the financial toxicities in cancer. And we will take questions at the end of the session. If you have questions related to this webinar topic, please type them in the chat function at the bottom of the Zoom screen. I am pleased to turn over to Sydney now for her presentation.
Thanks, Tara. Welcome. My name is Sydney, and I will be presenting on melanoma and skin cancer awareness today. So let's get started. Today, our objectives are defining melanoma, learning about the prevalence and clinical features of melanoma, as well as learning about screening and treatment and how we can prevent melanoma in ourselves. So we're going to start with the definition of melanoma. So the definition of melanoma is a type of skin cancer that develops when a cell called a melanocyte grows out of control. It's the most serious form of skin cancer, and it is the 5th most common cancer in men and women. As we age, we have a higher risk of being diagnosed with melanoma. Melanocytes, like I said, are cells that become the melanoma. They make a brown pigment change called melanin, which colors our skin tan or brown. And melanin protects deeper layers of the skin from harmful impact of the sun when it's exposed. Melanocytes are present in skin, eyes, in our nasal tracts, as well as our upper respiratory and GI and GU tracts. And thus, malignant melanoma can arise from cutaneous ways, which means it has a relationship with the skin or mucosal sites. There are multiple definitions of melanoma, and I think that is where there can be some confusion as to the stage and grading of melanoma. So I'm going to review a few types of stages that you may or may have not seen in the literature. The Breslow staging is a thickness of the lesion measured to the 10th of a millimeter, and you can see here today how that's displayed. It's been replaced by the American Joint Committee on Cancer staging system, but we have seen it in our past, so it may or may not still be in the literature. The AJCC systems assign staging based on tumor node and metastasis scores and other prognostic factors. And then on the right, we have the Clark staging system. This is scored 1 to 5 based on the deepest level of the layer of the skin, with 1 being confined to the epidermis and 5 invading the hypodermis. So level 1 is where the melanoma is confined to the epidermis, or that top layer. And then when you're moving on to level 2, the melanoma has invaded the papillary dermis, which is the outermost layer of the dermis, or the top layer of the skin. Level 3 is where the melanoma has invaded throughout the papillary dermis and is touching the next deeper level of the dermis. Level 4 is where the melanoma has invaded the next deeper layer or the reticular dermis, and level 5, the melanoma has now invaded the fat under the dermis. So now when we're looking at these, it looks as though it's thick, but when you think about it, 4 millimeters is about half of your pinky width. So the average pinky width is about 1 centimeter. So when you think about depthness, you're thinking about the half of a pinky width is when we're starting to get worried that it's becoming a more severe melanoma. So this is the new staging system, the American Joint Committee on Cancer. So this is kind of the new updated version, written in 2017. So I'm going to kind of go through that. So stage 0 is what I have labeled here is also called melanoma in situ, where the cells have only gone to the epidermis and the survival rate is about 98%. Then you're looking at stage 1, which is when it is no more than 1 millimeter thick, and this is considered local melanoma, and it also has a good survival rate. Stage 2 is when it extends beyond the epidermis into the dermis and considered local melanoma, which is also divided into 3 groups from 1 millimeter to 4 millimeters thick, or about half of that pinky width. It also has a very good prognostic factor or survival rate. Stage 3 is now called regional melanoma, where the melanoma has spread to the lymph nodes, lymph vessels, or the skin, and it's divided into 4 groups. You can see here that the survival rate has dropped significantly to about 63%. Stage 4 melanoma is when it has spread to other places in the body, and it's considered distant metastatic melanoma. Again, there's been a drastic decrease in the 5-year survival rate, which is why we're talking about this today, where it can change in stage pretty quickly. A little bit of facts on melanoma. So in the United States, the prevalence of melanoma, 2022 estimates for melanoma include about 100,000 new melanomas will be diagnosed, more men than women. About 7,650 people are expected to die from melanoma this year, including about 5,000 men and 2,500 women. The lifetime risk is different with different skin tones. So 2.6% in whites, 0.6% in Hispanic population, and 0.1% in Black population. So we're moving on to clinical features. And you want to think about when you have a skin lesion, questions that you can ask yourself are, how long have you had the lesion? And since you've had it, has it changed? Do you have a personal history or family history of melanoma? Have you had an excessive history of sun exposure or tanning bed use? And then have you ever suffered from severe burns in your childhood years? Are you immunocompromised, or have you ever received ultraviolet therapy? Ultraviolet therapy is usually given to people with skin disorders such as psoriasis. Other risk factors include having a light complexion or phototype, red or blonde hair, or having the presence of many melanocytic nevi or moles, and having more than 50. Other risk factors include having heavy density freckling, light eye color, including green, hazel, or blue eyes, smoking, excessive sun exposure. Our risks also increase with our age, and about 10% of these have a genetic component. Although the presence of common nevi is a strong risk factor, most of the melanomas start as new moles. So again, looking at your moles you already have, as well as if you have new moles that have accumulated. A 2017 meta-analysis looking at over 20,000 melanomas found that about 30% were related to moles and about 70% were related to a new mole that had been seen. Melanomas that start on the palms of your hands or the soles of your feet or under the nails is called lentiginous melanoma. Melanomas that start on the internal surfaces, such as the mouth or the vagina, are called mucosal melanoma, where there's been little or no sun exposures. So there's different types of melanomas. Melanomas, also called the ugly duckling. This is a sign based on observation that in an individual with multiple nevi, the nevi tend to exhibit one or more predominant or new specific looks. A pigmented lesion that is obviously different from others in a given individual must consider these to be suspicious, and so they should have them looked at. The predictive value of the ugly duckling has not been systematically studied. However, we do use it when we're teaching patients about what to look for. In 1985, dermatologists in New York University started using an acronym ABDCE to describe melanomas or to describe moles that patients should be going in and getting looked at. A stands for asymmetry. If a lesion is bisected or cut in half and it's not identical to the other half, that is a sign that we should have these looked at or biopsied. Border irregularities, where they're not having the same borders. Color variation, this means you have a mole that is 3 or more colors, and they can be shades of red, blue, black, gray, or white. When we're looking at diameter, you are looking at moles that are larger than 6 millimeters, which would be over half of your pinky width. And then evolution, looking at lesions that have changed in size, shape, color, or even a new lesion. Another scoring system that had previously been used is called the Glasgow 7-point checklist, in which they use a major and a minor score. The major score is looking at a change in size, shape, or color of a mole, and the minor scoring includes looking at diameter, inflammation of the mole, crusting, bleeding, or a sensory change. So other atypical warning signs other than your ABCDE includes having a sore that does not heal, a spread in pigment from the border of a spot to the surrounding skin, redness or new swelling beyond the border of a mole, change in sensations such as itchiness, tenderness, or pain. You're also looking to see if there's been a change in the surface of a mole, including scaliness, oozing, bleeding, or the appearance of a lump or bump. So now we're going to look at a few different types of melanoma so you can kind of see what we're looking at. So here are a few different kinds. The one on the upper left is from the bottom of a heel. When, again, we're looking at the palms of our hands and the soles of our feet for new melanomas. Again, we're looking for that asymmetry, border irregularities, which you can see at within the other photos displayed. Color variation, where you're looking at different shades, size, as well as evolution, where you're having the changing in size, shape, or color of a new lesion. Here are a few more that I'd like to show you today. So there it's showing the size. On the lower left is showing the size of 1 centimeter, which would be about 10 millimeters. The other one I'd like to point out is the one on the lower right hand, which is under a nail bed, which we're also looking for changes in the nails. So things that we're looking at for screening. So first we start with screening ourselves. So know your skin. Know the patterns of your moles, blemishes, freckles, and other marks. Check your skin once a month in a well-lit room. When I was reading to do this webinar, one of the articles I thought had really good point to one way to remember to check your skin is to check your birthday suit on your birthday. So remembering to do this on a regular basis. Check your skin once a month in a well-lit room, like I said, and hard to see areas that can have melanoma grow include the back of your thighs, your palms, soles, scalp, ears, nails, and back. You also want to be screened for melanoma by a health professional. Dermatology is a specialty that does the skin exams. Suggesting that the following indications for referral to dermatology include a new mole, a long-standing mole that is changing in shapes, color, or size, any mole that has had 3 or more colors or has lost its symmetry, a mole that is itching or bleeding, and any new persistent skin lesion that is growing or vascular in appearance and the diagnosis is not clear. You're also wanting to know or be concerned and have a referral if you have a new pigmented line in a nail where there can be associated damage to the nail and under the nail. You also should have a regular visit if you have a history of skin cancer. So how do dermatologists look at melanomas? They usually use something called the dermoscopy, and this is in the upper corner picture. The purpose is to reduce the number of unnecessary biopsies, and they usually detect melanoma 90% of the time versus about 71% with the human eye. They also use a lot of imaging. Reflectance confocal microscopy is an imaging technique that allows for identification of cells with histologic resolution. It has a very high cost as well as not time efficient. There are other techniques, including computer-assisted diagnoses, which uses algorithms using large sets of images or non-visual data that also helps in reducing unnecessary biopsies. Artificial intelligence includes looking at neural network systems and imaging that they can use to decide whether or not they want to do a biopsy. There are also multiple smartphone apps that are approved by regulatory agencies for the detection of these. So moving on to treatment. So these are the specialties that do the treatment for melanomas. A dermatologist is the doctor who sees the patient with a skin concern. A surgical oncologist is the doctor who uses surgery to treat the skin cancer. A medical oncologist is a doctor who treats skin cancer with medicines, such as chemotherapy, immunotherapy, or targeted therapy. A radiation oncologist is the doctor who treats the cancer with radiation. And then they also have multiple team members that help to complete these different types of treatments. So at Mayo, there's a shared division of breast and melanoma surgical oncology. They manage complex surgical conditions of the melanoma. They are experts in using melanoma surgeries to excise the melanoma, including sentinel lymph node biopsies, lymph node dissections, hyperthermia, interlesional therapy, lymph node dissections, as well as robotic pelvic lymph node dissections. Systemic treatment for melanoma is typically treated with immunotherapy and targeted therapy. These are the mainstays of systemic treatment at this time after surgery and in metastatic settings where melanoma has spread to another area. Immunotherapy agents commonly used at this time include ipilimumab, nivolumab, and pembrolizumab. You may or may not have heard of these. BRAF inhibitors are also used as approximately 1/2 of cutaneous melanoma have this genetic mutation. Radiation for melanoma is considered in patients with multiple risk factors to improve local regional control. Radiation is considered when the original tumor has ulceration present, satellite lesions, has a high depth, has positive margins, or is also local recurrent disease. Radiation is also considered for regional lymph nodes when there's extension through the lymph nodes, you have multiple lymph nodes positive, or if the size of the lymph nodes is greater than 3 to 4 centimeters. Radiation is used by itself when surgery would be disfiguring and in certain areas. And this is usually done with external beam radiation where you're not radioactive and it's done over multiple weeks' time. Side effects from radiation depend upon the site being getting the radiation, and they are including the dermatitis, which is some redness of the skin. Late side effects include fibrosis, hypo or hyperpigmentation, as well as lymphedema. So how are we going to prevent melanoma? Staying out of the sun is going to be the easiest. However, we're not able to do that all of the time. So you can do other things by protecting yourself from the sun, including using protective clothing, hats, sunscreen, and sunglasses. Tanning bed use is associated with an increase of melanoma, especially if you are using a tanning bed before the age of 30. So we need to continue to teach on the risks of using a tanning bed. We try to prevent infection with HIV, as this can weaken the immune system and put you more at risk for melanoma. The American Academy of Dermatology recommends a UVA and UVB protection, which is found in sunscreens, and they also recommend an SPF 30 or higher. We also want to seek shade, as the strongest rays are between 10 a.m. and 2 p.m. Other ways that you can stay out of the sun include using sunscreen when you're near water, snow, or sand, as these reflect damaging rays of the sun, which can increase your chances of sunburn. Use sunscreen every day that you are outside. And you want to reapply every 2 hours or after swimming, sweating, or according to directions on the bottle. Sunscreen can come in different types, including options of lotions, creams, gels, ointments, waxes, sticks, or sprays. So there are multiple types of sunscreen that you can use. So following up after you've had a diagnosis of melanoma is pretty specific to the patient. Early stage melanomas that are removed completely usually call for a physical exam every 6 to 12 months. Melanomas that have spread beyond the skin might include a schedule of physical exams every 3 to 6 months, as well as some imaging tests. Survivorship care plans individualized, suggest schedule follow-up for exams and tests, discuss possible late or long-term effects from the treatment. We also recommend a healthy lifestyle, which includes not smoking, eating well, being active, and staying at a healthy weight. At this time, there's no dietary supplements, including vitamins, minerals, or herbal products that have been shown to reduce your risks of melanoma returning or coming back. We also want to reduce our risks of second cancer. Melanoma survivors are more at risk for other skin cancers, including melanoma, salivary gland cancers, small intestinal cancers, breast cancer, prostate cancer, kidney cancer, thyroid cancer, soft tissue cancer, non-Hodgkin lymphoma. But the most common is another skin cancer. And I'd also like to share with you today that there are multiple clinical trials at Mayo that they have ongoing for treatment of melanoma. And that will conclude with my references. Any questions regarding melanoma?
Sydney, I do have one question here that has come through. Any tips for looking for melanomas that don't create pigment?
So that's where you're going to be doing that skin check and you're looking for like lumps and bumps. So knowing the surface of your skin. So you should be able to see that when you're in a well-lit room, like if it's something is starting to create a shadow, especially if it is a non-tender area. So we get worried about many types of cancer that stay the same as the regular pigment. So you're not just thinking about melanoma in that case.
Great, great. Also, there's another question. Can you explain what a lesion and a nevi is?
So they can be about the same thing. So a lesion, you're looking at like kind of like the last question. A lesion can be like a nodule or an area that's elevated and raised. A nevi is another medical term for mole, like a mole.
Okay, great, great. And then what SPF do you recommend for sunscreen again?
So it should be SPF 30, and it should say broad spectrum on it to cover different types of rays. This should be applied about every 2 hours when you are in the sun.
And does sunscreen expire to your knowledge?
It can expire. That's a true statement.
Great. And then there is another question on here too. How does immunotherapy work?
So immunotherapy works in different ways, but it blocks receptors to grow further melanoma, to be simplified.
Great. All right. Let's see. We'll just give it another minute and see if any other questions come through.
Excellent.
But yes,
Those are
that's
good
great,
questions.
great questions. Yes. I never would have known that sunscreen expires, but on a recent vacation, I did learn that actually. And it does have a different appearance than its lotiony appearance, that it actually became kind of clumpy.
Yeah,
So you can tell that that was definitely an expired
it does
sunscreen. So
expire.
yeah,
Look at
yeah.
your dates on your sunscreen before you apply it this summer.
Yes, yes. And especially for myself being, one of those people that you had described, I have the lighter skin, I've got the freckling, the lighter hair color and the lighter eye color. So all those categories are going to be extra careful, especially with the
Yes.
sun coming. Yes.
Yes.
I see you have a few, excuse me, a few more questions. Maybe I can
Oh,
help
oh
to
yeah.
jump in.
Yeah. Perfect.
Can you explain Mohs surgery? Is it different from excision?
It is different from excision. So Mohs surgery is where they are taking a layer at a time and then they review it while you're in the office to see if the margins are clear. And so they continue to take the layering until they have clear margins. An excision is where they go in and they go very deep to cut out all of it at one time. So Mohs is more progressive versus excisional is a one-time thing.
Are there facts on recovery from surgery versus radiation treatments, one better than the other?
So for melanoma, surgery would be the standard of care. And then what was the other half of the question?
Versus radiation treatments. So is one better than the other?
So surgery is going to be your main go-to as far as like getting rid of a primary melanoma, and radiation is going to be if something is not surgically like applicable, like if they're not able to get the whole lesion, or if you were to have recurrent melanoma.
Great. If you have a family history of melanoma and have children, at what age should kids begin to be screened?
So when you're taking your children to a primary care provider, they're looking at like they're doing skin exams and they would refer. So an annual exam with your primary is sufficient until there's a lesion that's found. And then usually after that, they are plugged into dermatology to see the child on a regular basis.
Okay. And then is mineral-based sunscreen better?
I don't know the answer to that question.
Okay.
There's no like supplements that they can see that like reduces the melanoma, and then mineral you know, I think of like an oil, and we usually don't use like an oil for sunscreen. It's usually like a lotion or a cream. So you want a skin protectant, not something that's like absorbed by the skin.
We often hear about tanning booths being so bad, but for a lot of folks, before they go on a vacation from winter months up in northern places where there isn't as much sun in the winter, before they go on vacation, is there any place for that, or really not? And your thoughts on the tanning bed situation?
I highly recommend not using a tanning bed, because we don't know, like you can't like justify a risk factor like based on each individual person. And when you're outside, like in the winter, you should be using sunscreen on a regular basis. But no, I would not recommend a tanning bed at any time.
Yeah, I think I heard a dermatologist say, don't quote me on this, but it was a crazy increased risk of melanomas for people who do that, So yeah, thank you for your comments on that.
Yes.
All right. Yeah, I don't see any other questions coming through.
I see there's one in the chat that says, any specific ingredients to avoid or to make sure are in sunscreen?
That's an excellent question. So if you go on the American Academy of Dermatology website, and I believe Tara and her team are going to be putting these references on the webinar later. If you go to their website, they talk about what is safe to have in sunscreen. And then they also talk about ingredients that are not approved by the FDA. And usually those are not sold in the United States that have those ingredients that would be dangerous to our skin.
That's great. Yeah. You just never really know what kind of ingredients that you're looking at with sunscreen, because there are so many different manufacturers out there, and, different variations. They say they cover this and it's all natural, and, you just don't know anymore. So it's great to have those references.
If it's sold in the United States, is pretty highly regulated by the FDA. But that list on the dermatology website does show ingredients that would be harmful if you were to buy it, like if you were on vacation in Mexico or Australia or something like that.
All right.
Other questions?
I think we'll give it just a minute, and if there isn't any other questions that will come through, then we will go ahead and end the session. I'm not seeing any more. Are you, Janine?
Nope, no more.
All right. Sounds good. All right. Well, if that's all that we have, certainly we will again have recorded this session. And like I said before, it'll take about 3 days to get this edited, and we will post this on our Mayo Clinic Connect site. And Janine was grateful and gracious enough to go ahead and put that link in the chat. So if you would like to click in there, and you can explore more on our Mayo Clinic Connect.
Well, thank you so much.
Thank you.
Thank you.